Well, I think we will go ahead and get started. There's a lot to get through today. Good morning. My name is Amelia Brayman. I am the Vision Care Advocate with Prevent Blindness Wisconsin, and I just want to welcome you all to our virtual Vision Connections conference. This was originally going to be an in-person event, but in the land of COVID, we have shifted to this wonderful virtual platform, but I think that has turned out better for us because it sounds like we have people from not only Wisconsin, but all around the United States as well. So welcome to everyone. Just a little bit of housekeeping here. Everyone will be muted until the Q&A portion of the presentation. Please feel free to use the Q&A. We will have staff monitoring the Q&A throughout the presentation, and there's no chat today. We also have closed captioning available. If you click on the More button on the bottom of your screen, you'll either be able to view subtitles or view the full transcript. And if you view the full transcript, it'll show up on the right side of your screen, everything, and then you can kind of read it as you go along. All right. Well, just a little bit of background on Vision Forward. Vision Forward helps infants, children, and adults, and seniors who have trouble seeing when glasses, contacts, and other medical interventions do not help. Their expert staff help individuals get connected to training and support to learn how to continue their independent lifestyle, maintain their employment, and experience products that help make everyday life a bit easier. Prevent Blindness Wisconsin's focus on vision loss prevention is completed through certified vision screenings, vision health education throughout the lifespan, vision insurance navigation, and community awareness. Prevent Blindness Wisconsin is an affiliate of Prevent Blindness. All of our vision health information and protocols are scientifically and medically validated by the National Center for Children's Vision and Eye Health and our Adult Scientific Advisory Committee. Both Prevent Blindness Wisconsin and Vision Forward are grateful for the support of the Racine Community Foundation and the Irving L. Chortek Estate for allowing us to co-present today. And with that, we will go ahead and get started. My camera will be off for the remaining of the presentation, but I will pop it back on when we reach the Q&A. Again, please feel free to type any questions you have into that Q&A chat box. And Corey, we can go ahead and go on to the next slide here. So today we are going to be talking about maximizing your eye health. So what can we do every day to just make sure we're helping our eyes be as healthy as possible? Next slide, please. So Prevent Blindness Wisconsin, we were founded in 1958, and our vision is for each Wisconsin resident to have healthy vision at every stage of life. We are a small office of 8 staff, but we are able to reach the entire state of Wisconsin. Next slide. So in our last fiscal year, we were able to reach over 325,000 Wisconsin residents, and a lot of that is through the help of our wonderful partners. One of our big programs is training individuals all throughout the state on becoming certified vision screeners so they can then provide that free service in their community. And we also provide educational resources such as this one today to help individuals learn more about keeping their eyes healthy. Next slide. Today we are going to kind of hit on these 4 main topics. So we're going to just briefly talk about the anatomy of the eye, discuss how lifestyle factors can impact our eye health, some common aging eye disorders, and the next steps. What can we do today to take care of our eyes? Next slide. So I just want to briefly talk about the anatomy of the eye, just so when we talk about those aging eye disorders, we have a little bit of a frame of reference. So the first area I want to touch on is the lens. And I'm not sure who is controlling the PowerPoint, but if you could hover the mouse over the lens, just so people might see where that is, and if not, that's totally fine. So the lens is where we're going to talk about cataracts. And then moving towards the back of the eye, we have the retina. And the retina is my personal favorite part of the eye. I know that's a weird statement to say, but hey, this is my job. So the retina is this amazing tissue that's able to take the light rays coming into our eye and convert that signal into signals that our brain can interpret. So it's really amazing tissue and that we want to make sure we are keeping very healthy. And then along the retina, we have this little notch called the macula. And the macula is responsible for our fine vision, our central vision. So when we talk about age-related macular degeneration, we're talking about the health of that macula. And then moving a little bit farther down, we have our optic nerve, and our optic nerve is what's going to transmit those signals back to our occipital lobe on the back of the skull, and that's what it's going to allow us to see. So we're going to talk about the optic nerve a little bit more when we discuss glaucoma. All right, next slide, please. So trends in vision. So we know that there are an increasing number of individuals with vision diagnoses. These trends came to us from Prevent Blindness. Each year they do a vision summit in the summer. And this was one of the talks that they presented on, was these trends. And I think some of them are really interesting and some we might not necessarily think about all the time being related with vision. Obviously, we know that an increasing aging population is going to cause those vision diagnoses to go up with it. As we get older, our eyes are one of the things that starts to be a little more troublesome for many of us. But some I think that are really interesting is the increasing number with obesity and diabetes. We'll talk a little bit more about how diabetes can impact our eye health with diabetes-related retinopathy. And also just increasing health disparities and an increasing risk of future pandemics. Both of those, we know that individuals who don't have access to vision care when they need it, whether that's because they don't have access due to not being able to get vision insurance, or early in spring when we had all of those shutdowns, a lot of people couldn't get to the eye doctor when they would normally go see their eye doctor. So both of those are going to make people more at risk for those vision diagnoses. And then also an increasing risk of, or an increasing number of individuals with depression. We know that low vision and having trouble seeing in your everyday life puts you more at risk for those mental health disorders such as depression. So I just think this is really interesting, and this vision conversation is not going away anytime soon. So I'm all really glad that you're all here with us today to learn a little bit more about that full spectrum of vision health. Next slide, please. So let's dive right in and talk about lifestyle factors in our eye health. Next slide. So the first one, smoking. Smoking, we know, greatly impacts our vision health. Smoking damages the blood vessels in our eyes, especially the retina. And remember, the retina is that amazing tissue at the back of the eye that we want to keep really healthy. And it also decreases blood flow to the macula. So decreased blood flow to the macula means that those cells are not going to be as healthy as they should be. They're not going to be able to function to their best capability. Also, decreased blood flow to the macula is what's going to lead to that eventual diagnosis of age-related macular degeneration. We know that smokers are 4 times more likely to suffer from AMD and twice as likely to have cataracts. Just think of all of those fumes and vapors right around our face are all going to get absorbed into our eye tissue. So that's why smoking, and then the next slide will be vaping. We just know that those directly can cause those eye diagnoses. Next slide. So vaping. Vaping has become extremely popular in the last few years, especially among our younger population. And a lot of that is kind of this advertising around vaping is a safer alternative to smoking, smokeless tobacco, all of those kind of buzzwords that they use. But we know that e-cigarettes are just as detrimental as smoking. Research is currently being done on how vaping directly impacts vision health, but all of the preliminary research is showing that it's just as detrimental. And a lot of that is because of all of those heavy metals, chemicals, the nicotine, cancer-causing agents in those e-cigarettes, all of those fragrances and flavorants and things to make them smell like cotton candy. None of that is good for our lungs, our body, or our eyes. Next slide, please. Alcohol consumption. So when we think about alcohol and want to talk about more of that heavy overuse, binge drinking, long-term chronic overconsumption of alcohol, not your, wine glass at dinner a couple nights a week. This is really that overuse of alcohol. But in the short term, those binge drinking episodes, we know that there's a lot of safety concerns around how alcohol interacts with our eyes, our vision, and our ability to respond properly. So we know that when we drink too much, we might get that blurry or double vision. We can have bloodshot eyes, a decreased pupil reaction, and irregular eye movements. And all of those kind of equal accidents, because if we've got that blurry double vision, if we're not able to react properly, that's when we get into car accidents, we harm ourselves or harm others. And then in the long term, that overuse of alcohol has been led to a diagnosis of age-related macular degeneration, cataracts, optic neuropathy, which is damage to the optic nerve. And then jaundice is that yellowing of the eyes and skin. And so we typically, when an individual is in those more late stages of liver failure, we can see that show up in their eyes. So the big takeaway, make sure that we're drinking responsibly, because alcohol can affect our eye health in both the short term and long term. Next slide, please. Screens. This is kind of ironic since we're all today watching this presentation through our screens and digital devices. And I'm sure if you're anything like me these last 6 months, it seems like you can never get off of your screens. But there are some ways that we can kind of help mitigate the impact of the screens and our eye health. So one thing I want to mention about screens is that one of the problems that we know that they can cause is a disruption to our sleep-wake cycle, also called the circadian rhythm. The blue bright light that comes off of our screens can trick our brain into thinking that it's daylight. So if we're on our phone or our laptop, iPad right before bed, that light coming off is going to trick our brain, and it's going to make us think that, oh, we don't need to turn that melatonin sleep hormone on. We'll just keep thinking it's daylight, and then we don't sleep as well. Another big problem is eye strain. I don't know if I'm the only one, but after a few hours of working on my screen, my eyes definitely feel really tired. I feel like I have to blink a lot, I rub them a lot, and that's that eye strain, that fatigue from sitting in front of our screens. And we do know that the long-term effects of overusing our screens can be a diagnosis of myopia. And this is something that we're seeing in our younger population. So typically we wouldn't see myopia or nearsightedness diagnosed until that more prepubescent time frame in a child's life. But because we're using mom and dad's phone, our Chromebooks, now we're virtually learning, we're seeing kids diagnosed younger and younger. By 2050, it's estimated that half of the global population will be myopic or high myopic. So again, this is going to be one of those buzzwords that we're going to hear a lot more, especially in this, as we've kind of continually are more in this digital landscape, just a good thing to keep in mind. Next slide, please. So what can we do to kind of make sure that we're kind of mitigating the effects of eye strain? The big thing is to take breaks often. We really push for the 20-20-20 rule. So what I like to do is I just set a little timer on my phone that'll buzz every 20 minutes, and it will remind me to look 20 feet away for 20 seconds. You might think 20 seconds, can that even do anything? But it actually really does. It allows those near muscles to kind of relax, and those distance muscles to get a chance to stretch out, to get strengthened. So that's a really great way that we can all, while working from home, working remotely, give our eyes a little bit of a break. We can also change the filter settings on a lot of our devices, especially the newer devices, have what's called a night shift or like a red shift in the settings. And what that does is that will make it so that your screen isn't so blue, but it has a more warm tint. And especially you can set it so that when the sun goes down, the screen, becomes warmer. So this is a great way if we're using our devices late at night, that it's not going to affect our circadian rhythm. Some individuals use those kind of blue blocker computer glasses to help with the effects of the blue light. But what we really recommend, especially now before the snow flies, is to get outside. Getting outside is a great way to really strengthen those distance muscles, get some natural sunlight, and give your eyes a break from the screen. Next slide, please. Dry eye, another effect of too much time on the computer. So dry eye occurs when the eyes do not produce enough tears, or the consistency of the tears is not effective in hydrating the eye. So some of these symptoms might be burning or stinging of the eyes, kind of feeling that like sandy feeling in the eyes, experiencing blurred vision, or having excess tear production followed by extreme dry periods. Next slide, please. Now, unfortunately, there's no cure for dry eye, but there are some methods that we can do to kind of decrease the severity of the symptoms. The first, avoid that cigarette smoke. The next one is to take fish oil supplements. Research has shown that the omega-3s in the fish oil can help kind of build up the lipid barrier on the outside of our cornea, which is that outside layer of our eye. So that's a nice kind of win if we're already taking fish oil, or if we're interested in starting a fish oil supplement, make sure you talk to your primary care physician. You can also use a humidifier in your room to keep the air more moisturized. And if none of those are working, you can always ask your eye doctor about the over-the-counter artificial tears or ointments to kind of help keep those eyes lubricated. Next slide. All right, we're going to move into our aging eye diseases. Next slide, please. The first one I want to talk about today is age-related macular degeneration. And again, remember the macula is responsible for that central vision. So when we look at the picture on the right, we can really see how without the healthy macula, our vision is really impacted. This is a pretty severe case of AMD, but we have that kind of black hole in the center of our visual field. Next slide. There are two forms of AMD, dry and wet. Dry AMD is the most common form and it's what everyone starts with. Dry AMD will result in permanent vision loss over time, and it's due to a buildup of drusen. Drusen are small protein deposits that build up underneath the macula. And unfortunately, we can't prevent the drusen buildup at this time. They are doing a lot of research on AMD right now to kind of try and stop it before it starts. But what some individuals do is if their doctor prescribes them an AREDS 2 formula, that's a multivitamin that has tons of different vitamins, zinc, lutein, to kind of stop the drusen from proliferating or continuing to build up. Some individuals do move on to wet AMD, and this is a more serious form because it results in severe vision loss quickly. And this is due to a formation of abnormal blood vessels underneath the macula, and this causes the macula to bulge out from its regular position. So with those blood vessels and that bulging of the macula, we're not able to get that clear vision because those cells are not able to work effectively. And so with this wet AMD, this is where we're going to see a lot of that big loss of central vision, and pretty darn quickly. Next slide, please. So some of the signs and symptoms of AMD are going to be just starting off with blurred vision. We might begin to notice a dark or empty spot in our central vision. Distorted, wavy, effective straight lines. And with this one, I always think about how in those early stages of AMD, if we might not know that we have this disease yet, that driving down the road could get really tricky for some individuals if those lines begin to kind of appear wavy when they're really straight. Trouble discerning colors, especially from dark to light, and then similarly difficulty going from bright to low light. All of these disorders that we're going to talk about today, though, are pretty darn sneaky, and some of them don't have any symptoms until the disease has pretty started to progress pretty far along. So that's why we're going to harp on for the rest of this presentation the importance of going in for your dilated eye exams. Next slide, please. So risk factors. So AMD risk factors. The first one, aging. Unfortunately, just as we get older, our cells are going to change, and so we might develop that AMD. Some individuals will have a family history. There's a pretty significant population though that is at risk for AMD, and that is Caucasian females with fair colored eyes. They think this is due to kind of the lack of melanin, just makes you more at risk for that AMD. Also, individuals who have hyperopia or farsightedness. We're not quite sure of the exact connection between this and AMD, but individuals who do have that diagnosis are more at risk. And then if you are a smoker, we know you're 4 times more likely to develop AMD. Next slide, please. So next steps, so what can we do about AMD? 1, know your risk factors, especially if you fall into any of those categories where you either have a family history, you have fair colored eyes, you have farsightedness. Make sure you're talking to your eye doctor about your risk factors. Wear as high of UVA, UVB sunglasses as you can when outside to protect your eyes. Quit smoking. Monitor for those vision changes if you start noticing those wavy lines, the blurry vision. Make sure that we are going to the eye doctor when we start to see those changes, and then make sure we're going in for a dilated eye exam. Next slide, please. All right, cataracts. So as we can see from our image on the right here, that cataract has that really washed out effect on this beautiful Wisconsin farm field. Next slide. So cataracts are due to a protein buildup in the lens. And as we can see from this image on the left, when we have that cloudy lens, the light is not able to hit a sharp point in the back of the eye. It's kind of diffused over the retina. And that's going to lead to that blurry, kind of blown out image. There are 4 kind of main categories of cataracts. First, just being age-related, again, that unfortunate part of aging. There's also congenital cataracts. So some individuals might be born with a cataract, could be genetic, or could be due to trauma during the birth. Then there's also traumatic cataracts. So if an individual is in a car accident or a sports injury, they might develop a cataract. And then unfortunately, cataracts can be developed as kind of a secondary diagnosis. One of the main ones that we will discuss today is the connection between diabetes-related retinopathy and cataracts. Next slide, please. So some of those symptoms might be that blurred vision, double vision, or that kind of film over the eyes. If you start to feel like you need brighter and brighter lights to read, or that you feel like you need a stronger and stronger prescription in a pretty short period of time, if you're going to Walgreens to get those reading glasses and every couple months you need that next one up, make sure that you are going to your eye doctor, because that's kind of one of the best indicators that we might have a cataract. We don't typically see this as much in the United States, but if the cataract kind of goes on long enough, we can develop a milky or yellow spot in the pupil. Globally, cataracts account for 50% of all of the cases of blindness in the world, but it's one of the most treatable eye diagnoses. So it really just shows that in parts of the world where they don't have access to good vision care, many individuals become blind by something that is a pretty simple outpatient procedure here in the United States. Next slide, please. So risk factors. So obviously there's that genetic component. Diseases such as having diabetes will be a risk factor for developing cataracts. Long-term corticosteroid use, not the muscle-y steroids, but the corticosteroids, can also put you at risk for developing cataracts. Those eye injuries, kind of like we talked about, those traumatic cataracts. Smoking, again, twice as likely to develop a cataract. And then long-term unprotected exposure to sunlight. So this is something that for individuals who work outside all day, so landscaping, construction, any of those fields, we really want to make sure that they are educated on wearing sunglasses, wearing hats, because that long-term exposure can be a risk factor for cataracts as well. Next slide. So next steps, again, knowing your risk factors. If you kind of fall into any of those categories, make sure you're keeping cataracts at the back of your mind, especially when you're going in for your dilated eye exams with your eye doctor. You can ask them about your risk factors for cataracts. Again, wearing sunglasses, quitting smoking, and then monitoring for those vision changes, especially that feeling of needing brighter lights and needing a stronger prescription. Next slide, please. All right, diabetes-related retinopathy. So as we can see here, that's going to kind of cause those dark splotches on our visual field is the best way I can describe them. Next slide. So diabetes can damage the blood vessels in the retina. The retina, again, is that really sensitive tissue at the back of the eye. And there's two forms of diabetes-related retinopathy, non-proliferative and proliferative. So non-proliferative is our early stage. And in this stage, the blood vessels in the retina are beginning to balloon and swell. And then as we move into those proliferative stages, those blood vessels begin to grow abnormally. And this is called neovascularization. And you might be thinking, well, that's great. More blood vessels in the retina. It's going to be so healthy, so much more nutrients, all this blood going there. But unfortunately, those blood vessels are really weak. They're fragile. They like to leak and kind of break apart and spew their contents. And they also grow in places that we don't want them. So this blood vessel growth is actually really detrimental to our vision. Next slide. With diabetes-related retinopathy, this is one that we often see. There's often no early warning signs, again, because in the beginning, those blood vessels are just kind of beginning to swell, and it takes a while for the neovascularization and leakage to occur. But some individuals do have blurry vision. A few notice a really sharp increase in eye floaters, so all of a sudden it just seems like a crazy amount of floaters. Make sure you're going to your eye doctor. Some people might see flashing lights or halos around lights as well. Next slide. So the biggest risk factor for diabetes-related retinopathy, unfortunately, is that diagnosis of diabetes. Another risk factor is how long you've had the disease for. So for individuals who have been diagnosed for a longer period of time, typically we might see a more severe stage of retinopathy. And again, diabetes-related retinopathy can be a risk factor for then going on and developing cataracts and glaucoma. So that's why it's really important that we are going to the eye doctor and making sure that they are monitoring the health of our retina. Next slide, please. So the next steps, number one, we're monitoring our blood sugar levels and we're keeping them in the range as prescribed by our eye doctor and physician, whatever our physician recommends for our blood sugar levels, that's what we want to keep it to. We're also including movement and a healthy diet into our lifestyle. We're taking our diabetes medication as prescribed, another really big one for controlling those blood sugar levels. And then it's really helpful, if possible, to create a medical home for vision. So what that means is that you have the same eye doctor that you go to each year for your dilated eye exam. This just helps you kind of create that relationship with the eye doctor. They can become very familiar with your retina, so they can quickly see if there's any changes. But it's just a great habit to get into when possible to kind of create that medical home for vision. Next slide, please. All right, the last disorder that we are going to talk about today is glaucoma. So glaucoma is kind of that opposite of AMD. Instead of the central vision loss, we have that peripheral vision loss. And this is why glaucoma has the nickname of the sneak thief of sight. Next slide. So glaucoma is kind of an umbrella term for a group of diseases that cause damage to the optic nerve. So when we talk about glaucoma, we're talking about the pressure in our eyes. The two types that we're going to talk about today are open angle and closed angle glaucoma. So with glaucoma, I want you to think about a city street and water, it's rained and water is just flowing right down into that sewer. That's what we want to happen with our eyes. There's fluid that's getting moved throughout our eyes constantly, and then it's exiting our eyes. And if everything is going well, all of that fluid is just washing out as it's supposed to, and we're not developing an increased pressure. But let's say it's October, all of the leaves are falling from the trees, and there's kind of some blockage on that drain. So some of that water isn't flowing as well as it should. That's our open angle glaucoma. Over time, if those leaves continue to keep blocking the grate, we're going to start having some of that fluid kind of building up in the city street. And over time, that's going to cause more pressure in the eye. And so that's going to start damaging our optic nerve. Closed angle is the opposite problem, or is a more severe form of glaucoma. So now we've cemented over that drain. There is no water getting through, and now the street is flooded. So all of a sudden, we're going to have a really sharp increase in pressure in our eyes that needs medical emergency. We can lose our vision pretty quickly with closed angle glaucoma. So if you ever feel like you just have this horrible sharp pain in your eye, make sure you're going to the emergency room because it needs immediate treatment to maintain your vision. Next slide, please. So glaucoma, again, a lot of people, especially in that open angle stage where we just have that slow buildup of pressure, might not experience any symptoms. When we do start to see symptoms, we might have that loss of vision, especially on our periphery, blurry or foggy vision, having a hard time going from going into dark rooms, seeing rainbow-colored rings around the lights. But even without those warning signs, we may still have glaucoma. So this is one that we want to make sure we are getting our regular dilated eye exam for, because we don't want to wait until we already have that high buildup of pressure, that damage to our optic nerve. Next slide, please. So what are some of the risk factors? Some of us just genetically have a higher intraocular pressure than others. Again, aging. And we see glaucoma highest among African American, Latinx, and Asian American males. So some of that is genetic, and also some of that has to do with the shape of the eyes and how the fluid is draining from eyes. So those are the populations that are kind of most at risk for glaucoma. And this image on top here, this is a tono pen. So I don't know about you, but I always hated the puff of air going to the eye doctor. That was kind of the older test for measuring the intraocular pressure. Now they have this nice tono pen, so no more puff of air, so no more excuse for not going in for your dilated eye exams, because this is much more comfortable for the patient. Next slide, please. So what are our next steps? Obviously, number one, going in for that dilated eye exam, knowing our risk factors. But another really important thing to touch on with glaucoma is that we're following our treatment instructions as prescribed by our eye doctor. So if we're diagnosed with glaucoma, it's a chronic condition, and most people need to take some form of daily drops or pills, anything to keep that pressure in check. So unfortunately, we've heard that individuals, due to the cost of their prescription, might cut their dosage in half, might do 1 drop instead of 2, might do drops every other day. And unfortunately, that's not going to help treat your glaucoma. So we really want to make sure that we're instructing individuals to follow those instructions, because that's the only way to keep that pressure in check. Next slide, please. So what can we do today to protect our eyes? Next slide. This is the last time I'll say it, I promise, but the number one thing we can all do is schedule our dilated eye exam. So as you can see from this image on the left, when an eye doctor is looking at our eye that is undilated, they're only able to see a small portion of the retina, a sliver. It's only when our eye becomes dilated that they're able to see the full back of the retina, that macula, that optic nerve. This is the only way that they can monitor the health of our eyes so that we know if we are starting to show those early warning signs of AMD, cataracts, glaucoma, and diabetes-related retinopathy. So when make sure you're going in for your dilated eye exams. Also, you get a better prescription. It's just a more accurate reading. So that's another big bonus. And I know it can be a pain. It's hard to drive after, it takes a long time, but it's definitely the #1 thing we can all do to keep our eyes healthy as we get older. Next slide, please. So how often should we get a dilated eye exam? Because it kind of changes as we age. So if you are between the ages of 20 and 59 with no vision risk factors, you would be safe to go every 2 to 4 years for your dilated eye exam. Once we hit that 60-year or older mark, we should be going in every 1 to 2 years. Next slide. Although if you do have special risks, such as a diagnosis of diabetes, previous eye trauma, family history of glaucoma, or any of these other eye diseases, you may need an eye exam more frequently. So when you go to your eye doctor next, ask their recommendation for how often you should be getting a dilated eye exam, because it might be unique to you and your eyes. Next slide. So nutrition. This is an easy thing we can all do every day for our eye health. Obviously, we all know that carrots, wonderful carrots, are good for our eyes, but there are so many other fruits, vegetables, and foods that are wonderful for our eye health. So some examples here are tomatoes, those dark leafy greens, eggs, salmon, again, high in those omega-3s, olive oil, corn, citrus berries, and almonds. And if you follow us on Facebook, we like to post a bunch of eye health recipes. They're really easy, just like this blueberry peach smoothie, just a few ingredients and all packed with eye health ingredients. So follow us at Prevent Blindness Wisconsin for some more of these delicious recipes. Next slide, please. Sun protection, another thing that we can all do every day to take care of our eyes. So sunlight is great for our eyes, only in moderation. We know that UVA can damage the macula, and the UVB rays can damage the lens of our eye and the cornea, so that outer layer of our eye. So again, make sure that we have as high possible of UVA, UVB protective lenses, and that we're avoiding those peak hours of sun between 12 and 4. That's when the sun is going to be the strongest. And also wear a hat, just another layer of protection, especially if you are going to be outside for a long period of time, or if you work in a field that requires you to be outside all day. Next slide, please. All right, so I hope I've encouraged you all to get off of this call in a little bit and schedule your dilated eye exam. We made this little checklist to help make it easier to remember what you need to bring when going to the eye doctor. So always make sure that we're bringing our insurance card or our Medicaid, Medicare card in a form of ID. Sunglasses for after that dilated eye exam so we can safely drive home. Make sure you bring your most recent glasses or the reading glasses that you are using. And then I always like to kind of think about what I want to ask my eye doctor before I get there, because it's inevitable that we have a great appointment, but oh shoot, I forgot to ask on that one item. Now I have to wait a whole nother year. So maybe give it a moment, think about what you want to ask about if you feel like you fall into any of those categories for the eye disorders that we talked about. You can ask about your risk factors. We also have a ton of wonderful information on our website, wisconsin.preventblindness.org, that has tons of eye health information in addition to what you learned today. Next slide, please. So we are just going to do a quick survey here, just 5 questions, and you can just type it in the Q&A, true or false. So we can go on to the next slide. So question number 1, true or false, the most effective way to protect your eyes is to receive a dilated eye exam. True, wonderful. We can go on to the next slide here. Smoking is a risk factor for developing cataracts and AMD, age-related macular degeneration. True or false? True again. Wonderful. Everyone's coffee was kicking in this morning. All right, just 3 more questions here. So next slide. You should give your eyes a break from screens every 30 minutes. True or false? False. Yes, we want to follow the 20-20-20 rule. So every 20 minutes, we're looking 20 feet away for 20 seconds. Next slide. Carrots are the only good food for your eyes. True or false? Wonderful. False. Got so many delicious foods that can be healthy for our eyes. All right, and then the next slide. All right, so not wearing eye protection outside is a risk factor for developing cataracts. True or false? True, exactly. Thank you all for taking my quick survey here, and we can go on to the next slide. So if you enjoyed this presentation and you would like to support Prevent Blindness Wisconsin, we recently got this text to give function. So you could just text vision to 243725 if you would like to support Prevent Blindness Wisconsin. And you can also find more information about the work we do statewide on our website, wisconsin.preventblindness.org. Next slide here. Perfect. Well, I think we're going to open it up to questions. Actually, could we go on to the next slide? My contact information should be on that one. Wonderful. We can just leave this up while people are asking questions. So if something came up today that you would like more information on, I saw a question about forms for facilities. So whoever had asked that question, feel free to email me. We have tons of handouts on all of the eye diseases. If you're in Wisconsin, we have eye care provider lists for every county. So lists of all of the eye doctors in each county. If they have translators, if they have wheelchair capabilities, we have tons of information like that. So feel free to get in contact with me. And I think we're gonna open it up if anybody wants to type any other questions or ask a question out loud. We can feel free to do that here. Wonderful. Well, I'm going to stay on for the Vision Forward presentation. So if you think of a question, you can pop it in the chat box. I'd be happy to answer, or always feel free to shoot me an email or we can have a chat over the phone, whatever you prefer. And I'd be happy to share any of that information that you are looking for. Thank you so much for watching today, joining. And with that, I think we can move on to the next presentation.
So now we're going to chat about the differences between
Good morning. I'm going to just give everybody just a couple of minutes to take a little break in case you need to take a bathroom break before we jump in. We'll just pause for a couple of minutes and then we'll get going. I'd like to thank Amelia Brayman. She did a great job presenting information about the eye and the eye health. I am a huge advocate for the 20-20-20 rule. And anybody, who uses any kind of electronic devices or loves to read can benefit from using the 20-20-20 rule. And even if you have visual impairment, that 20-20-20 rule is important. Oftentimes when our patients are getting used to learning how to use, can't hear? Lauren, can you say something?
Yeah, can people hear me?
Yeah, we can hear you now. It cut out at the very beginning, so you're
Okay.
We're back? Okay. People who are learning to use magnification can benefit from that 20-20 rule. Set the timer for 20 minutes, work with your magnifier for 20 minutes, then put it down, come back to it after you've had a chance to take a break and rest your eyes. So I wanted to give people a little break, but you know what? You can always mute yourself and head out to the bathroom, come back. My name is Dr. Heather Hinson. I've been providing vision rehabilitation services here in the Milwaukee area for over 30 years. I am proud to be a part of a team of professionals, a dedicated team of professionals here at Vision Forward for 22 of those last 30 years. One of my colleagues is Lauren Nelson. I'll let her introduce herself.
Hi, like Dr. Hinson said, my name's Lauren Nelson, and I'm an occupational therapist at Vision Forward. I've been working here for about 12 years, and I'm also a certified low vision therapist, so I'm specialized in the area of low vision.
So I think we're going to mute ourselves now. We have a kind of pre-recorded video. You know, one of the conversations I have with my patients all the time is, in order to be successful with magnification, you have to step out of your comfort zone and do things a new way. This is our opportunity to kind of practice what we preach, because this is way out of our comfort zone, doing things virtually and pre-recording things. So hopefully everything will go well, and we'll see you at the end of the presentation to answer any questions.
So now we're going to chat about the differences between a low vision evaluation and a routine eye exam. I guess it's easiest to start with what a low vision assessment is not. We're not going to be doing any of the scans or pressure checks or putting you behind the microscope or putting drops in your eyes. Everything we do with a low vision assessment revolves around function, trying to help you use your remaining vision to access and do the things that you want to do. So let's start out. One of the first things we're going to do, you can't get to us here at Vision Forward without having had your medical eye evaluation. So you need to have had a recent dilated eye exam before you can come to Vision Forward. And the reason for that is we want to make sure that everything is being done that can be done to preserve and restore vision from a medical perspective. But once you get to us, one of the first things we're going to do is we're going to go through your eye history. Before you come in, I will have reviewed your medical records, and so I'll know what is causing your vision to be blurry. I will check into asking questions about have you noticed any recent changes in your vision? How long ago did this vision loss start? Have you had this problem for years, or has it been a sudden change? I'm also going to want to know what your exposure has been to low vision rehabilitation. Have you worked with somebody using magnifiers in the past? Have you just kind of gone online and purchased your own things and have been just kind of trying to do it on your own or with the help of family members to learn how to use adaptive devices? So we want to kind of get a feel for what you've been doing. This is your chance, as we're reviewing your eye health history, this is your chance to ask questions about the diagnosis, about the prognosis. Where is this going to end? Are there any new surgeries, or are there any new procedures that might be able to enhance my vision or stop the loss of vision? And if we don't know the answers, we'll certainly look it up for you and get back to you with the best answers that we can. So things like, I will ask my patients, hey, did your doctor give you one of those Amsler grids? It looks like a piece of graph paper with a dot right in the center. And oftentimes my patient will say, yeah, I got one of those. And my next question is, how often do you check that grid? And my patients will tell me, they'll get kind of sheepish and say, well, I'm not sure I know where it is right now. I don't check it that often. Maybe once a month I'll look at it. And then I'll ask them the question, well, why did your doctor give you that grid? And my patients will tell me, well, you know, to see if my vision changes. And I said, yep, that's accurate, but what does it tell the doctor if your vision changes on the grid? And then we can go into the discussion of the importance of the Amsler grid, and that your doctor gave you that grid because he wants you, we want to be able to see if there's a slight change in the vision, because that may indicate that your dry macular degeneration is changing over to the wet macular degeneration. And checking that grid on a very, very frequent basis, like at least every other day, is very important. If we wait for Mother Nature to do her thing, and the dry converts to the wet, you're going to see a sudden deep drop off in vision. But if you're checking that grid, we can often detect the conversion early, which will allow the use of injections to be more successful. So as we review your eye health history, this is the opportunity for me to educate you on why you're maybe doing some of the things that you're doing, and for you to ask me questions to clarify things that your ophthalmologist may not have had an opportunity to go through with you. The biggest thing we do as part of the history is we want to establish goals. So I always ask the question, I know that if I asked you, what would you like to see better? The obvious answer is, well, everything. I want it all. I want to be able to see everything better. And that's a great goal. But we need to know where to start. So let's take and put a list together in order of importance. What would be the number one thing you'd like to see better? Some patients want to be able to read the large print Reader's Digest. Some people want to be able to do photography. Some people want to be able to paint. Others might want to knit or sew. You know, what is it that you want to be able to see better? Don't tell me my vision's blurry or what you can't do. I want to know what you want to be able to do. And it even goes to be so specific. Somebody says, I want to read. I'm going to ask you, read what? Because the tool that you might use to read the crossword puzzle will be different than the magnifier that you might use to just sit down and read for leisure, like a chapter in a book. It's all reading, but it's different types of reading. And the magnifier that might be the best magnifier to have on hand in the kitchen to be able to read your measuring spoons or to be able to read your recipe, again, that may be different than the magnifier that you would use to read the words on the TV screen. It's all reading, but it's different types of reading. So getting as specific as possible will help us help you. Writing is another big one. Patients often say, oh my goodness, my handwriting, I used to have such beautiful penmanship, and now I can't even read the list that my grocery list that I've written. Those are things that we can help you with. When we work with children, figuring out what it is that they're having difficulties with in the classroom or maybe doing homework, part of what we want to help you do is be efficient. You might already have the tools in place to help you see the small print, but is it going to take your child or you, it's going to take you 30 minutes to read one page in the book? Is it going to take your child 2 hours of homework when everybody else in the classroom was able to get that homework done in the classroom, didn't even have to bring it home as homework? So we want to not only allow you to see the small print, we want you to be able to see it efficiently and in a relaxed manner. I talked earlier about the differences in what people like to do. Are there any hobbies you stopped doing because of your change in vision? These are all the things that we need to know. We're going to put together that list in the order of importance so that we can kind of go through that list and find the tools that would help you accomplish what you want to see. Another big thing for our patients who might have diabetic retinopathy, glaucoma, retinitis pigmentosa, is the ability to get around safely, the ability to, especially when it gets dark, the ability to get around their own home, the ability to go into a crowded grocery store, to be able to go to their grandkids' activities where there might be a lot of people and get around safely. So part of what we're going to ask you is, have you had any falls recently? How are you doing if you don't have a family member there with you? Are you able to get where you need to go? So when we look at this screen here, I've got some pictures of some different eye charts. Down and to the left, there's a picture of the standard Snellen chart that you would use in a routine eye exam. Usually the lights are down in the room and the eye chart is projected on a screen or into a mirror, and all you see is the letter across the room. Up and to the right is a picture of my low vision chart. You'll notice that you can see all the detail in the room. You can see the door, you can see the screen. I want our environment, when I'm checking your vision, I want the environment to be as natural as possible. I had a gentleman in the other day and he told me, he said, you know, oh doc, it's too bright in here, you got to turn the lights off. And I said, so what are you doing when you're driving and there's a lot of glare? I actually want the environment to be challenging, if you will, because you're going to, in real life, you're going to come into those circumstances where the environment is challenging. And then what are you going to do? I don't want it to be optimal conditions to enhance your vision. I want it to be maybe even a little bit challenging so that we can find the tool or the device or the technique that will help you when you're in those challenging environments, whether it's too dim or it's too bright, too much glare. So the lower, kind of down and in the middle of the screen, I have a picture of a couple of different reading charts. And again, these are different than the ones you get when you go to your eye doctor for your routine exam, because one, they have more size print on them. The one to the left has got just the letters. The one to the right has got paragraphs. Identifying a couple of random capital letters on a chart is very different than reading a paragraph. When you're looking at a paragraph, you've got long words and short words and punctuation, and you've got crowding. So you've got row upon row upon row, just like in the newspaper, in a column in the newspaper. You might be able to really do well identifying 5 random capital letters on an eye chart. But then when you have to go to read the newspaper, it all falls apart. Those are the kind of things that we assess as part of a low vision assessment. Not just what can you see on a high contrast chart, but what can you see in the newspaper where the contrast is low or where there's so much print on the page that you kind of get lost. We're going to determine what distance you hold things from your nose. As I mentioned earlier, we want it to be not just clear, but we want it to be efficient, and we want it to be enjoyable. We also take the opportunity when we're assessing your visual acuity to see how well you're using your peripheral vision. A lot of the patients we see here at Vision Forward have macular degeneration. And macular degeneration is a disease that affects your central vision. So it's the part of the retina that you use for seeing a grain of sand, for seeing bright, vivid colors. It only takes up, the macula, believe it or not, only takes up about 5% of the entire retina. So what does that mean? That means you got 95% of your retina still working just fine. One of our goals is to help you use that other 95% of your retina. An eccentric viewing is a technique where you learn to turn your eye in the direction that allows you to use that peripheral vision better. Some of the patients we see have a condition called nystagmus, where their eyes wiggle back and forth. This is common when somebody has a congenital vision loss or a vision change. Maximizing the null point is helping the person to get their eyes in the position where that eye wiggle is at its minimum. So those are just some examples of things that we're going to try to help you do as part of a low vision assessment. Now on this, every patient I see, and I'm not kidding you, it's pretty much every patient I see, and I've been doing this for 30 years, will come in and say, nope, you know what? I already had my eyes checked. My eye doctor said new glasses won't help. And I'll nod my head and I said, you know what, that might be true. We might find that the glasses you walked in with today are the best prescription for day-to-day things. But what we're going to assess as part of a low vision evaluation is that eyeglass prescription you walked in with the absolute best prescription to be combined with other types of magnification? In that situation, it might actually be different. So the picture on the left, you see the person behind that mask. It's called a phoropter, and that's the lens where they ask you which is better, 1 or 2, which is better, 1 or 2. And that's a very, very artificial environment. You're looking through kind of like a set of binoculars almost, where it's a very, very small field of view, and you can't turn your head, you can't turn your eye to use that peripheral vision. So it's kind of limited in allowing a natural vision setting. On the right, you'll see a set of trial lenses. There's a frame in there, kind of a heavy, loose frame. It's not the most comfortable frame, but it's a great tool that allows us to simulate what a potential new eyeglass prescription might be able to do for you. It also puts you into free space, which allows you to turn your head or turn your eye to use that peripheral vision more effectively. So we really, really like having the opportunity to get you out from behind the mask and actually put on kind of a simulator pair of glasses to see how a change in prescription might enhance your vision. So on this screen, we've got all kinds of different magnifications. So when I'm working with a patient, so typically when we schedule a Vision Forward, we'll schedule the initial evaluation will be a 2-hour appointment, an hour with me and an hour with the occupational therapist. When you're with me, in a nutshell, I'm going to be checking three things. First, what can you see today? What's your vision? Right eye, left eye, both eyes together as a team. Second, I'm going to see how you respond to magnification in the distance. Third, I'm going to see how you respond to magnification up close. Once we figure out how much magnification it's going to take to help you see, whether it's the small print on the TV screen or it's a small print on your cell phone or on your computer, once we figure out how much magnification it's going to take to help you see the things you want to see, then the fun starts, because that's when I'm going to turn you over to the occupational therapist, and she's going to pull out all the tools that are appropriate for you. So let's just use an example of maybe a +10 lens is the best lens to help you see the stock market quotes in the newspaper. Well, guess what? That +10 lens will come in the form of an eyeglass prescription. It will come in the form of a handheld magnifier. It will come in the form of a stand magnifier, kind of like a paperweight. It will come in the form of the stand magnifier and the handheld magnifier will come with lights or without lights. It'll also be available in what we would call digital or electronic magnification. You can change the contrast when you're using a digital or electronic magnifier. So it's not just, it's one power, but that one power comes in many, many different forms. And we're going to try to introduce you to all those different devices and tools, let you get your hands on them, let you practice with them, and let you figure out which tool is the most comfortable tool for you. And so just as I said, you know, I have the easy part, figuring out how much magnification it's going to take to help you see better. But then I turn you over to the occupational therapist, and that's where we really put you to work, where you have to try out those things and let you see which one you like best. And so now I'm going to turn the PowerPoint over to Lauren, my colleague, who is an occupational therapist.
Hello, it's Lauren here. I'm the occupational therapist who works at Vision Forward with the adult low vision clients. So like Dr. Hinson said, when she's working with clients, it's in her office setting and she's working with a lot of charts. And so she definitely tries to make it natural, but it's still charts which have white backgrounds and dark writing. So the role of the occupational therapist is to take all the information that we get from Dr. Hinson and apply it to the client so that they can be as independent and functional in their daily lives. So these are just some examples that you can see of just some of the activities that people do every day, from shopping to using the computer to reading over-the-counter menus, newspaper, different hobbies, and so on. When we work with clients, we're treating the person as a whole. We're not just treating their vision loss. So what that means is that we need to get a lot of background information about the clients before we actually start working with different devices. So some of the questions that I ask the first time I see the client is, how long have they been living with vision loss? This makes a difference because somebody who has had vision loss for years is going to be in a different state of readiness to work with different devices, usually than somebody who might be brand new to vision loss. We also want to know the living situation and the support network. So for example, does the client live alone? Are there other people in the house? Maybe the client has to take care of somebody else? And also, what type of support network surrounds the client? Are there family members that can help, friends, neighbors? And maybe the person doesn't have much support network, just depending on circumstances. This is all information that we'd like to know. We also want to know different medical issues that the client has in addition to vision loss, because if there's physical limitations, that can definitely make a difference in how well a person can use some of our devices. We also talk about the emotional aspect of vision loss. I would say pretty much everybody that we see has some form of, I guess, depression or anxiety, frustrations, sometimes loneliness, sometimes they feel like they're a burden. Sometimes people are doing really well. And so we just kind of want to know where people are at emotionally with their vision loss. We also want to know if anybody, just concerns that people have related to living with vision loss. And these can be different for everybody. I wrote down transportation because that's a big one for a lot of our clients. A lot of people, they worry about how they're going to get places. They might have family members that can help them, but a lot of times what I found is that they tend to just ask for help for transportation for the most necessary activities, and they tend to stop doing things that they used to do just for enjoyment. And there's other concerns too. Sometimes people might have a concern that they're gonna fall, or they might have concerns that they can't use their phone if they need to make a phone call. So just any concerns we can talk about. And then we also go over just a daily, what are the person's daily activities? On a regular day, what types of activities are they doing? Because a lot of people come to Vision Forward because they're struggling with reading, but we can address any activity that is done throughout the day, no matter how big or small it is, if they are being affected by being able to perform that activity because of their vision. So whether it's, something as small as getting the toothpaste on the toothbrush, all the way to doing something more extensive, like maybe they're working and they need to do work-related activities, whatever it might be, we can address in low vision services. I also just want to know what the person was like before they lost their vision. What types of activities did they used to enjoy? What activities have they stopped doing because of vision loss, or have just become much more frustrating? So these are all questions that we're going to talk about on the first visit. Then we're going to talk about the goals, which Dr. Hinson already got the person thinking about what their goals are. But what I do is fine tune them, and we have to make them measurable. So the goals have to be client-centered. So they're not goals that I come up with or that family members come up with. It really has to be what the client, what's most important to the client. The goals have to be realistic. So, if somebody wants to drive, but they really just don't have the legal acuity that is necessary for driving, then that would not be something that we could focus on. The goals have to be specific. So Dr. Hinson already explained that reading is a goal, but we need you to specify exactly what it is that you want to be reading. And the reason is because there are different devices that work best for different purposes. So if somebody's going to do paragraph style reading, that's going to be different than somebody who just wants to read the total amount of a bill that they get in the mail. And then I also ask my clients to prioritize their goals. I want to know what is the most important to them, because I want them to be satisfied with services. And I've found out over the years, I've been doing this for 12 years, that the best way for people to feel heard and satisfied is for them to choose what order we do the goals, or what order we tackle the goals. So the low vision process, You start off by seeing Dr. Hinson, and that can be a one-time session with Dr. Hinson, and it usually lasts 45 minutes or so. From there on out, it's usually going to be working with the occupational therapist. And you can see the occupational therapist anywhere between 3 to 5 sessions. We do clinical visits, but we also do home visits. It just depends on the situation and the client's needs. I like to address the goals in the client's natural environment as often as possible. Goals can be added or changed. So we talk at the first session about goals, but that's not the end of it. Goals can be added or changed at any time throughout our sessions. When all the goals are met or addressed, then that is when we can talk about discharging the client. The client can return for services at any time. So if all the goals are met and we discharge the client, and let's say 3 years later, maybe there might be a change in vision, or maybe the needs change, the client can always return for further services.
And the only thing I would add to that is technology is changing so rapidly. So, the patient who comes back in 3 years, it may just be that things have, yeah, the stuff I have is still working pretty well, but I just want to know if there's something new out there. Has the technology changed? Is there something new that might work better than the things that I've been using for the past 3 years? So technology is changing rapidly, so it's not a bad thing to kind of check back in just to see if there's anything that might work better.
And that's exactly right. That's not uncommon for people to come back to Vision Forward. There really hasn't been a whole lot of changes to their life or even their vision, but they're really just curious to see what's new. And there's always new technology. Okay, so I'm going to talk just a little bit about the difference between non-optical solutions versus optical solutions. So I try to start with non-optical solutions if it's appropriate, and usually to some degree non-optical solutions are going to be appropriate for most clients. So non-optical solutions would be solutions other than using magnifiers and different optical devices. So I have a big long list here. I've got lighting and contrast, glare control, organization, font styles, the type of print that's used, covering up an eye. A lot of times we find people read better just by covering up their worse eye. The positioning that they're using when they're doing different activities, auditory and tactile. So instead of using vision, maybe using other senses to be able to help them perform activities. And then the scanning techniques and eccentric viewing, which Dr. Hinson was saying before, that's when the person is using their peripheral vision rather than their central vision. So I like to start with the non-optical solutions because they tend to be, they're just easier. Magnification, it certainly has its place, but when people use magnification, reading is almost always going to become a little slower. And also usually there's other, we call them rules of optics. There's other negatives about optical devices that make them just a little bit more challenging to use. And we definitely go over all of those rules in low vision services. But with the non-optical solutions, people are usually already familiar with them. They just might not know the best way to get set up to use them. So task lighting versus ambient light, this is a big one. There's people that come into us and we find that just by bringing in task light, they can read. It's just a matter of getting the light in the right position and also the right type of lighting. If you go to a store that sells a lot of lights, you know that there are a lot of different options and light bulbs. The aisle for light bulbs at some stores is extensive. So we narrow it down for people to make it understandable. And we show them how to position the light to get the most effect. The best type of light is light that you just put inches away, usually. this is usually, it's not for everybody, but usually the best type of light is light that is inches away from what they are trying to see. So ambient light that lights up the room is usually not the best type of light. Usually task light is better. And so I have some pictures here of people using different forms of task lighting in different settings. Another thing that we talk about, a lot about actually, is contrast. So dark on light, light on dark. The more contrast that is surrounding somebody's environment, the more able the person with low vision is going to be able to perform different activities. So if you look in the bottom left corner, there's coffee. So something as simple as putting coffee in a white mug is going to make it easier to see than if it's in a black mug where it blends right in. I also have the picture with the toothpaste. Putting white toothpaste on a white toothbrush makes it much harder to see than if there's contrasting colors. And then I also have a set of stairs here just to show you when there's an all black staircase, a person with low vision is going to have a hard time being able to identify the individual stairs. Doing something as simple as putting white tape on the edges of the stairs can really make them pop out and make them easier to see. Another thing that we talk a lot about is just how to function in your everyday life in the most efficient manner possible. So when somebody has a vision loss, anytime that there's visual clutter, which is just kind of a lot of stuff in a small amount of space, it's going to be hard to find what they want to find. So that could be at the grocery store when they're trying to find something on the shelves. I have here a picture of a bathroom sink, and there's just all kinds of clutter on there. So as OTs, we help in this area by talking about organization and just different marking devices, how to find things easier, just to make people more efficient and less frustrated. We talk about large print. You can find so many things in large print these days without even having to look very far. Telephones, remote controls, keyboards, calendars, word puzzles, books, Reader's Digest. I mean, there's all kinds of things that you can get in larger print now to make things easier for people to see. Another thing is font and style. So the clock on the top is very simple and it has a good font. The clocks in the bottom row, either the font style is a little bit too fancy, or the contrast isn't great, or there's patterns. The one on the left there, everything's good about that, except they threw in some floral patterns, which for somebody with a vision impairment, that can be challenging for them to kind of make out what they actually want to make out on the clock. Technology, so many of our clients now have technology. They have smartphones, they have e-readers, they have laptops and computers, and just so many different devices out there. What a lot of our clients don't know is many of these devices have built-in accessibility settings that are already installed into their devices. They didn't know that they were there and don't know how to use them. And so just by taking their devices and making some changes, just by going into the settings, a lot of times our clients can use these devices, they can use them more easily. Sometimes people are holding like a magnifier or something over their monitor trying to see it better, and they find out that it's really not necessary to have to do that. They can just apply some of these accessibility settings and then they can use it without having to use another device. Auditory or tactile use. So there's talking books, talking watches, talking scales. There's lots of things that talk nowadays. And in addition, there's different ways that we can mark up appliances, remote controls. We can put bump dots on different, just different things in the house. I've put bump dots on plugs to help people plug things in. I've put them on keyholes so that people can insert their keys a little bit better. So really, it just, whatever the client is having difficulties with. And like I said before, it doesn't have to be a big thing. It could be something very, very small sounding. But if it causes them frustration, then it's something that we can address in low vision services. And usually there's a solution. Combinations are key. So typically when we're talking about non-optical solutions, it's not just one thing. It's usually putting a combination of things together, like having large print, but also good contrast, good font style. Sometimes it helps if they cover up an eye. So that when people come through low vision services, we help them figure out the best setup to do different activities. And we talk about all these combinations and how they can maximize their vision and also just how they function. So there's definitely a time and place for optical devices. And often people that come here do benefit from either one or several optical devices. Like Dr. Hinson was saying before, there's different types of optical devices that can help people that are the same power. So what we have to do, or what we do during low vision services, is we figure out what are the most appropriate devices for that individual person and help train them to use them.
Lauren, I liked your previous slide that showed an actual toolbox. That's what I tell patients. We're going to help you put together your vision toolbox. Everybody who owns a home has a hammer, a saw, and a screwdriver, and you would not use a screwdriver to cut a board. Magnifiers work the same way, and I think that's one of the big surprises that patients have when they come for low vision services. They come in with one magnifier saying, well, this magnifier doesn't work, kind of with the mindset already that, well, magnification is not going to help because the magnifier I have at home doesn't work. It's just that they weren't using the right tool for the right job. So, you have to kind of get in the mindset that I'm putting together my vision toolbox. And depending upon what my goal is, come back to that goal, you've heard us say that word a lot today, what is the best tool to achieve that goal? So the toolbox is really, kind of keep that in the back of your mind, that it's going to take a couple of things to do all the things you want to do.
Yes, and I'm glad Dr. Hinson pointed that out, because otherwise you were probably wondering why I had a toolbox on there. Okay. So there are several different low vision devices, ranging from hands-free in the form of glasses to handheld devices. Most people initially want new glasses when they come. So really, and that's usually what's in the back of their mind. They want something easy like glasses that they can just put on and do what they want to do. The reality is that, because I had mentioned before something that we call the rule of optics. So there are different rules that our clients have to follow with each optical device. Typically, one of those rules for glasses is that they have to hold whatever they're reading a lot closer than what they have done in the past. Sometimes it could just be even a couple inches away from their nose. So glasses sound good initially, but when people try them out and realize that it's not the same way it used to be, maybe they want to read a book and it's heavy having to hold it that close. Sometimes it's better to use a handheld device or an electronic device. So when we're trying to figure out the best devices, we're factoring in, first of all, what are the goals? Secondly, what is the client's motivation level? Because when you bring in any type of optical device, it's going to be a little bit more work than in the past. And also, so it's the client's motivation, but also how willing is the client going to be to do this at home? So, they might be willing to give it a try in the clinic, but at home on a daily basis, is this something that they're really going to use, you know, to do whatever it is that we kind of had planned for it to be used for. So maybe it's newspaper reading. Are they going to use a pair of glasses and read their newspaper every day if they have to hold it that close to their face? So there's just a lot of considerations that we take into when we're thinking about the different optical devices for different clients. Electronic devices can be very helpful for a lot of our clients because you have a lot of control. You can change the contrast. So on the right side, you can see that there's a black background with white writing. On the left side, there's white background with black writing. You have the option, so you can change it. You can also change the size with electronic magnification. So you have a lot of control over how large you make the print. These devices, however, are more pricey, and some people just struggle with them for different reasons. We have electronic wearable devices, so that's taking the electronic, the form of the electronic devices that I just showed, but putting it into a wearable device that a person can wear over their eyes. You can see these look a little different. Definitely you would have to do a trial and maybe even a couple trials to see if these were right for you. But they do allow the person to change the contrast and change the magnification in a hands-free device. We do make referrals to different people at Vision Forward and other places as well. So if somebody is having difficulty with mobility, we have a orientation and mobility specialist that works here that can help with cane training. We have technology specialists that can help with you know, just any of the technology that people are using. And also if people are preferring to have material read out loud instead of using their eyes for visual reading, we have specialists that can train people on those types of things. We also have a specialist here for ADL, so that would be cooking and you know, doing some things around the house. And we have social worker and we have support groups. So there's a lot of different other professionals that work here that we can make referrals to. I also make a lot of referrals to the Talking Book program, which is a free service for people with vision impairments through the Wisconsin Talking Book and Braille Library.
All right, Lauren, thank you. Hopefully we were able to convey things. So we would like to open it up to any questions or comments. Our Director of Operations, Jackie Borchert, is going to, two ways you can get your questions to us. You can either type them into the question and answer box, or Jackie is going to give you the ability to unmute yourself. So if you want to just use your microphone on your device and just ask the question, we can get the question that way too. If you have, if you're participating in this webinar on your phone, you would need to dial *6 to be able to ask your question. So we welcome any questions that you might have. I want to mention also earlier in the question and answers, Nicole Feist had made a comment that, you know, remember if you're a veteran, that you can access your veterans benefits to get low vision services. We partner often with the VA to help clients, especially in some of the funding for these things. One of the things unfortunately, the way the system is set up now, Medicare and in private insurances will pay for the time that you spend with us, for the evaluation, for the assessment, for the one-on-one training, but they don't often pay for the devices. So if you're, you know, looking for ways to, you find a tool that you absolutely love, but you don't have it in your pocketbook right now to pay for some of the things, and you're a vet, you know, reaching out to the VA might be a way to get some funding for devices.
Yeah, and Dr. Hinson, I also just wanted to say, one thing I forgot to mention is, when should you come to Vision Forward? So the earlier the better. You know, what I like to tell people is, if you are struggling with really any daily activity, you would be appropriate for our services, as long as you're struggling because of vision, and if the vision cannot be corrected with standard glasses. You don't have to wait on, you know, because I've had people come and they feel like they're here too early, and that's not the case. If you are struggling with any daily activities, come visit us.
Sometimes if the vision is relatively good, and yeah, as Lauren mentioned, you're kind of nervous, like, well, maybe I don't need your services just yet, I'm not sure. Giving you the peace of mind that there are tools available that you may not be aware of, that heaven forbid your vision should change in the future, you know that there are things available that could help you in the event that your vision would change. And it can kind of give you that peace of mind to say, okay, I'm okay, I can do this.
Yeah, and I think it also helps if your vision is progressive, where it's going to worsen over the years. It helps to start sooner, to get acclimated and familiar with some of these devices and techniques. Let me see, I think let's see.
So the PACE coordinator through the VA has put a comment up in the question and answer saying the VA will pay for devices even if you did not develop the eye disease during your service or caused from service duty. This changed recently. The VA will give a lot of devices, but in many cases they require training so that a person knows how to use a device and goes and does not become a paperweight. Here at the Zablocki VA in Milwaukee, one of the OTs that works there used to work here at Vision Forward. So I can speak for them saying, yep, she does a great job. I know the optometrist there who provides some of the low vision services. It's a great team at the VA. Not to tell everybody to go, who is a vet, to go there, because we'd love to see you here, but to know that they provide great services out at the VA. Lauren, you got the filter one?
Yeah. Okay, good question. So the question is, you didn't talk about color filters. Do you use them? And if yes, how much benefit and any suggestions? Very, very good question. And the answer is yes, we do. One of the main things that we do is a glare assessment. So glare comes in, you know, when people are outside and traveling, but also a lot of the indoor things that people are doing, whether it's monitors or even just window light, TV, computer. We have a lot of different filters here in different variations of color and also light to dark. So we definitely do glare assessments with different filters to see if there's any help. Do they help? It depends on the individual and their feedback. You know, there's research out there that indicates certain filter colors with certain diseases, but I've just found that it's unique and it's something that you just have to try with each individual and go based on their personal feedback. So I hope that answers that question.
Before we wrap up,
Hi.
and to hop on, this is
Hello.
Amelia from Prevent Blindness, Wisconsin. I did just also want to mention that if you are an individual that does need help accessing your vision health insurance, if you need to help finding an eye doctor, or maybe just having trouble if you have Medicaid or Medicare, you can contact our office if you live in Wisconsin, and we will be able to help you through that process as well. And we do also have a voucher program that can provide a free pair of glasses and an eye exam. It is income dependent, so if you would like more information on that, please feel free to contact me. I will put my email again in the Q&A, but I also just wanted to give those resources as well. Thank you.
Hello. Hi.
Yes.
Hi, I'm Shirley. And
Hi, Shirley.
hi, how are you?
Good.
Thank you for having this webinar. It's really helpful and informative. I wanted to mention that I live in Massachusetts and we have a Commissions for the Blind. Is there a Commissions for the Blind in Wisconsin? Because they pay for, once you get declared legally blind through your eye doctor, they send the information to our Commissions to the Blind. Then they set you up with getting services, and they make assessments to provide free devices paid for by the federal government. Also, I think Medicare pays for some of the devices as well, you know, as needed. So I just wanted to mention that and wanted to know if Wisconsin or any other states had such type of agency for the blind, Commissions for the Blind. Ours is Massachusetts Commissions for the Blind.
Mm-hmm. Do you want to take it, Dr. Hinson, or?
You know, because you do more with the devices, and I'm
Yeah.
thinking what comes to mind, a couple of things, is the DVR for those people who are working to be employed. The Division of Vocational Rehabilitation helps to get funding for devices. The Office for the Blind and Visually Impaired is also an organization that will help with funding if a person can't afford it. Independence First, I mean, there's a lot of organizations in Wisconsin that may be able to partner with a person to help them with getting the devices. But Lauren, what can you think of any others? Or Jackie Borcher, if there's anything that you can think of to chime in on?
Well, I was going to just say that if somebody is interested in like the Department of Vocational Rehab, then it's up to that individual to reach out and fill out the application. And same with the OBVI, the Office for the Blind and Visually Impaired. The person will have to reach out and let them know that they need help. Vision Forward, we have we have everybody in one building, so it's you can come here, and we are a small nonprofit organization.
Right.
But it's nice because we have Dr. Hinson and the OTs in the same building. We have everybody, the O&M, the technology, ADLs, we have everybody here. So we can service, anything in one area.
Right.
And we get a lot of DVR clients, and that's the Department of Vocational Rehab. A lot of DVR clients come here for services as well.
Okay. Yeah, because our Commissions for the Blind also has the social rehab. So, those are the people who aren't looking to go back to work, but there's a certain budget that's given to that group, and they also provide them with the devices that they, after assessments are made. And then some of the nonprofit agencies such as yours, they work together with these Commissions for the Blind agencies to to make the assessment, and then such as maybe your organization would make the referral to one of the blind agencies stating that this particular client needs this type of device, and then it goes into approval status through the Commissions for the Blind agencies to see whether they're going to provide that to the consumer. And I just wanted to mention that.
Yeah, no, I'm glad that you mentioned it. And absolutely, we do work with these other organizations, and we refer people as appropriate. Yeah.
Okay. All right. Well, thank you so much.
Sure.
This is Susan Eggold. I'm on staff here at Vision Forward as well. And I want to mention that we do have a social worker on staff, and she's a great connection in helping people figure out what other resources might be available, both within Vision Forward and then throughout the state of Wisconsin. So she's great at making connections.
This
this is Lisa Chrissy at the Center for Deaf Blind Persons here in Wisconsin. We have a program, I Can Connect, and with that program, many of the older adults who have a vision loss also have a hearing loss. And with that, they can be assessed to see what equipment they would need to continue having long distance communication. So they are not cut off from the world. So there is another program out there, the I Can Connect or ICC, just putting in that little tip in there for people who might not be aware of it.
Thank you. And that is invaluable information. The dual sensory loss is really a challenge. Even for us, Lauren, I don't know if you would agree that that's, we do the best that we can, but when you're dealing with the dual sensory loss, it makes it challenging to communicate well and to have the ICC, which I believe helps with some of the funding things. Lisa, is that not correct?
What happens is you are assessed, and any equipment that you need, you will receive free of charge, and you receive the training so that you are using, like you said, it doesn't become paperweight.
The training is so vital. Yeah. So very, very important. We have patients come in with bags full of magnifiers and devices, and well, where did you get these? Well, I picked it up here, or I inherited it from my aunt or my uncle, and they just don't know how to use it. And after training, which is so vital to success, we actually pull things out of their bag and say, hey, I do have stuff that'll work for me. I don't need to make an investment in something new because the stuff I already have is actually helpful.
Dr. Hinson and Lauren, this is Jackie. There's another great question in the Q&A in regards to assistive technology and some of the higher tech devices like the OrCam or the eSight. And so I'm wondering, Corey, I don't know if you would be able to comment on that. Otherwise, I'd be happy to at least start the answer to that question.
Well, go ahead, Jackie.
Okay. So we have a technology and education center at Vision Forward, and we really are focused on ensuring that we have some of the latest cutting edge technology available to our clients. And as Lauren mentioned during the presentation, our low vision team and our assistive technology team work together very closely in terms of making determinations if individuals may benefit from some of these higher tech devices. And the two that were referenced here, the OrCam and the eSight, those are both what we call wearable devices. So these are some hands-free head-mounted devices, and they can perform some different functions. So the OrCam device does that text-to-speech. So Lauren mentioned that oftentimes the low vision team will then connect an individual to our assistive technology team if they're interested in some of those text-to-speech options. So essentially what that means is that the OrCam is a device that can take a picture of printed text and actually can transform that into speech. So if there is a newspaper article or a document, a photo can be taken of that, and then that will be read out loud for the individual. So that can be a really valuable device for individuals who maybe have more limited vision or experience a lot of fatigue when they're reading. The eSight device falls into that category of those wearable electronic magnification. So on her slide, Lauren had pictures of a couple different devices. There is a whole host, and this is a rapidly growing category of these wearable electronic magnification devices. And so one of the things we try to do at Vision Forward is to ensure that we are staying up to date on those and that we have a variety of those different devices for individuals to try. The devices can be really powerful, but there are definitely limitations with the device as well. Because they're head mounted, they can magnify movement. Because they're higher tech electronic devices, there is a little bit more of a learning curve to help individuals become comfortable with them. But for some individuals, these can be incredibly powerful and life-changing. So this is definitely part of the program and what we can make available to people, and certainly part of that potential toolkit, toolbox that's been referenced based upon, again, what those goals are, what an individual's interests are, and really their comfort level in terms of navigating some of the more advanced types of technology. So again, to that point of that Lauren made about the fact that we are the only organization in the state of Wisconsin that provides a comprehensive service for individuals of all ages. So if an individual initially connects with us through the low vision program, we can then help to connect them in-house to many different services, including assistive technology and the other areas that Lauren mentioned, orientation mobility, connecting with others through a support group or a mentor program, those sorts of things as well.
Jackie, I also want to say, for people who are interested in, you know, some of the more technology or the wearables, the Tech Talk Lives that our technology team do, they put these out, I want to say, like, is it once a week? They're excellent. And so, yeah, they really do a nice job of giving the viewer, you know, advantages, disadvantages, a real good look at how these devices work.
I'll pop in and
yeah, please,
plug
Corey.
and plug ourselves here.
Yeah.
Luke and I, this is Corey. Luke and I both do the Tech Talk Live series. It's every other Thursday. It's coming up this week. Coming up next week, Thursday. It's 11 a.m. Central Time. We always pick a topic. We also release demonstration videos every Friday on our YouTube channel. And you can find all the information on both our Tech Talk Live series and our YouTube channel. Best place to head over to is vision-forward.org/webinars. And you'll find all the links there. But they're very informative, and we enjoy doing them as well. The other thing I just wanted to mention, because there's so much technology out there and so many of these products can be not only expensive, but also can, like Jackie mentioned, they work for some and they may not work for others. And so we do highly recommend what we call our tech demo. We do invite individuals to come on into Vision Forward free of charge, sit down with myself or Luke for an hour, and we can take a peek at one of these devices, or sit down if you say, I really want to be able to use my iPad. What's available for us? We'll sit down with you for an hour, no charge, and we can sit and kind of find out what the best solution is for you.
There's another question. This is Jackie again. There's another question in the Q&A in regards to how our organization is paid. That's a wonderful question. So as we mentioned, the low vision services are considered a medical service. So we are able to bill an individual's medical insurance in order to pay for that direct time with the doctor or with one of the occupational therapists. So if an individual has Medicare and a full coverage supplement, typically their out-of-pocket expense is very minimal. And we do ensure that before an individual comes in for services, that we are doing an insurance verification and providing the best possible information about what your insurance coverage is. As a nonprofit, our goal is always to ensure that there are not financial barriers that prevent an individual from coming in and accessing services. So we can certainly work with individuals to make sure that the services are affordable and that does not create a barrier. However, with that being said, because of the fact that we do work to subsidize our services and make them accessible to all, it is really critically important that we do a lot of fundraising for our organization. As we mentioned previously, our organization serves infants, so we work with children as young as a couple weeks old, all the way through our senior population. And in some of those cases, the services that we provide are either not funded by other payer sources, or only the payer sources can only cover a portion of the cost and the expense of having the highly specialized services that we do. So as an organization, we raise over $1.2 million a year to help to allow our services to continue to be offered. And those dollars are raised through the generosity of our donors, through foundations. So we work really hard to ensure that we can continue to make our services available going forward. We do have fundraising events, and if anyone is ever interested in participating, you can check out our website, and there's information about those events and ways that you can help to support our organization. In addition, we do have our one of our premier fundraising events coming up on November 1st, which is a Dining in the Dark event. And that event will be done for the first time virtually this year. So it's a great thing that people could do from the comfort of their own home, learn more about our organization, and then have a really fun opportunity to eat a meal under blindfold and have that experience and reflect upon that. So certainly encourage individuals if they're able to participate, but ultimately our organization is here and does the hard work that we do in order to ensure that we can make the things that we're able to offer accessible and ensure that ability to pay never impacts people's ability to get what they need to help to achieve their goals.
And I just want to say too, if anybody is interested in the services at Vision Forward, you can refer yourself. You don't need a doctor's referral, although we do get a lot of doctor referrals, but you can refer yourself, a family member can call. So it doesn't have to come from a doctor. We do require medical records within the past 6 months from your doctor.
So there's a question on how big is your territory, or how far can the person come from? I mean, I don't think there's any restriction to how far you can come from or you're willing to travel from. Our geography for patients that come to us, we're southeastern Wisconsin. We've got people coming up. We've had patients from Illinois. We've had patients from as far north as Green Bay, as far west as Madison. So that's probably a 45 to 60 mile range from where we are would be kind of the max. In terms of, Lauren, you would know better, how far, if you're going to do a home visit, how far do you travel?
I guess it kind of depends. It depends. I've done them an hour away before. It really depends on how far the person is willing to come visit us, because ideally we would like to have at least a couple visits in the clinic.
Right.
And then, maybe even 3 visits in the clinic. It depends. So I think it depends more on what the person is willing to do. I'm willing to work with, you if you want to come here.
Right, right. I don't know if that answers the question that you were asking, but.
And with some of our services, there are some things that we're able to do virtually. We had some services that were available prior to the pandemic that were available virtual, but we have looked to expand those services. So the actual low vision visit is really best done within the clinic, because we really want to make sure that you have access to all the types of magnification and other things that Dr. Hinson is doing as part of her initial evaluation, and be able to get hands-on. So those are challenging things to translate to a virtual format. But particularly in the area of assistive technology, there are certainly options in terms of ways that assistance can be provided for individuals who live a further distance away. So my recommendation would be reach out, have a conversation with us. We want to be creative and want to ensure that people's needs are being met. And ultimately, if we're not the best fit to provide the service and are aware of other resources in your area, we can help to connect you to that as well.
And we have been recently, with this whole Corona thing, looking at, how can we do remote low vision assessment? It is being done, but usually there's somebody local who can do some of the hands-on stuff. So we may partner other clinics, big clinics throughout the country who are doing virtual low vision assessments, are kind of partnering with a local occupational therapist or somebody local who can help with some of the hands-on stuff. But it certainly isn't out of the realm of possibilities that maybe we do, we gather some information from your local eye doctor, and then maybe send you a packet of things, and then get on virtual and do some training with those things. It's being done in other clinics, and as Jackie said, if you have questions and your distance is maybe posing a problem for you, give us a call. We'll see what we can work out with you. All right. Well, are there any questions out there? We just want to make sure we didn't miss anybody who might be trying to access through their microphone. Speak up or forever hold your peace. All right. Oh, go ahead.
No, I just said okay.
Okay. All right.
Thank you. I appreciate the show. It's really great. I'm here in California.
Oh, wow. Wonderful. Thank you for joining us.
Yeah. San Jose, California. Our local help is a Vista Center of San Jose, of Palo Alto. Actually, got 3 branches: Palo Alto, San Jose, and Santa Cruz.
Wow.
And And then also at our branch, we have our tech guru, Ernie Molina. He puts on a Zoom technology thing the third Friday every month from 10 to 12 Pacific time. And anybody's invited. You could contact Vista Center and get the information.
All right. Well, if there are no other questions, then thank you for the information, Ken. Appreciate that. Everybody likes getting the access now that we're getting more technologically savvy, having access to this information. I see. I just want to make sure. All right. Nope. We got that. So I would like to thank everybody for participating and bearing with us as we get used to this, our new normal in the virtual world. If you have any questions for the staff here at Vision Forward, you can give us a call. You can contact us at area code 414-615-0100. You could shoot us an email at info@vision-forward.org or visit our website at www.vision-forward.org. I would also like to thank the Racine Community Foundation and the Irving L. Chortick Estate for their support and allowing us to partner with Prevent Blindness Wisconsin on this webinar. You should be kind of on the lookout for a survey that we're going to send to you by email. We appreciate any feedback, what worked, what didn't work, so that we can go forward, get the most out and make the most of these types of webinars. Thank you so much. Repeat the phone number. Yep, absolutely. The phone number here at Vision Forward is area code 414-615-0100.